welcome to the Virtual Physiatry Mentors. I'm Dr. Sheena Bhuva.
I'm Dr. Benecia Williams.
And together we are
Benecia.
Boom, boom. Right. Well, today we have Dr. Amy Ng. She is a fellowship, or she is currently practicing at MD Anderson doing cancer rehab. And so she's going to tell us a little bit about how she got to that job and kind of what all cancer rehab involves. So thank you so much for joining us today. We're very excited to have you.
Yes,
absolutely.
You.
Thank you guys so much for welcoming me and having me on the show.
Yay. So tell us a little bit more about yourself. Tell us where you are from, where you did your training at, and where you're practicing at now.
Absolutely. So Texas was not really my intention. Somehow I ended up in Texas at MD Anderson, but I started a while ago, probably in medical school when I knew I wanted to do rehab. And then after that, I matched at Baylor University Medical Center in Dallas, Texas. And then after that, I just really, cancer rehab just really took off. And I was able to get basically my dream job. And I went to MD Anderson in Houston. So yeah, been there since 2012.
Where did you grow up at?
In North Carolina, so Chapel Hill, Durham area, and then I went to my undergrad at Wake Forest in Winston-Salem, and then went to my medical school at UNC Chapel Hill.
Awesome, yeah. Very good.
And I was on my way to California, and somehow I stopped in Texas, and I couldn't ever leave. So
it does that to us outsiders. Yeah. It does.
Yes,
it sucks us in.
Yes. I don't know. Yeah, somehow I'm still here.
Yeah. Me and you both, sister. Never would have thought I would have left California, but here I am.
Exactly. I was on my way there, and Texas just grabs you, and here you are.
That magnetic pull, you can't leave. Yep. So you mentioned that while in medical school you knew you wanted to do PM&R. So how did you come across, or how did you hear about PM&R in medical school, and then during residency, when did you decide that you wanted to do cancer rehab?
So in medical school, we actually had our third and fourth years for elective. And so it was actually one of my orthopedic friends that was like, you should go and try this PM&R. And they really are very like you. You want to help patients. You want to, you have like these feelings, instead of being a surgeon. So where they just like do this and then they're done, and you want to help people. This might be your field. So actually I did a month with the PM&R rotation at UNC Chapel Hill. And I think you guys featured them before.
Yeah, we had a
UNC Chapel
takeover.
Hill. Yes. Yeah. So I actually watched that as well. A lot has changed since I've been there. And some of the professors there, the attendees were just absolutely wonderful, and they really pulled me in. They really showed me what it was like, and I got to experience all different, the different bread and butters. But I said, this could be something that I could do, and it was also like combine my love of medicine with the actual like helping of like sports and people with brain injury and strokes. And I just said, you know what, this is something I wanted to do. And then when I was in residency, I really didn't hear much about cancer rehab because it is not your typical bread and butter. But, I did love that. I just loved the inpatient part where there was a lot of medicine. And actually at that point, I think like my third or fourth year, like towards the end of the third year, after we did a little bit of cancer rehab, I actually said, this could be something. I started looking at the fellowship and got more information about it. And I would say back then, probably not as much, definitely not as much information on cancer rehab as there is now. And also we did not have as much exposure. So I went and I looked up everything. Like at that time, there were only I think like 2 fellowships, one in Houston and one Memorial Sloan. So I looked at both of them and I said, do I want to give up another year of my life? Should I do this? And I actually thought about it, and to me, it was worth it. So I did apply for a fellowship, And actually, I didn't get to go to fellowship. They hired me as an attending instead. So at the end, I learned everything through my fellowship on the job training. And looking back, probably, I wish I would have gotten more exposure, like there were more people to tell me about cancer rehab, what we needed to do. But somehow, through work and through experience, I gained all of that knowledge and still continue to learn. Don't get me wrong, there's just so much out there that's, still ongoing. And the fellowship, we now, if you look at it now, there's, I don't even remember how many programs there last was, but I think 6 or 7 that are
Yeah, something
accredited.
like
So
that.
yeah, so really it's grown so much in the short time. It's amazing.
It really has taken off. I remember probably like right about the time RPGY for time, like cancer rehab started getting very, very hot, and started learning a lot more about it. And I know Dr. Hamilton was trying to build more of a relationship at the acute side with because we would always get consulted like every now and then to go over to the cancer center,
Right.
and then just bringing the most of the time it's lumped in. And that kind of brings me up to my next question is cancer rehab is a smaller subspecialty, and it's often lumped in with general rehab. As we all know, at training at Baylor, we got a lot of cancer patients would come in on our general service. But can you tell us just more about the subspecialty and exactly what you do?
Absolutely. I love to tell people, about cancer rehab, because definitely physiatry, the field is growing. Our residents are, starting just to get a small portion of it. And I give this talk with grand rounds about, what is cancer rehab, and I start by looking at, for AB, PM&R, what do they want us to know about cancer rehab? Unfortunately, there's a big chapter in Cucarillo, but unfortunately, all the questions on the boards basically were lumped into medical rehab, and so maybe 1 or 2 questions, but most bread and butter would be like TBI and the brain injury, but really we don't get enough of the cancer rehab. But I think that yes, it is part of like medical rehab. Definitely, we do a lot of medical rehab stuff, but we are specialized because we just focus on cancer patients. So I usually show this graph where this figure where, for example, like if you had let's say you had a bad knee, that's one event, and basically something happens, your knee is bothering you. So you go downhill, you fix it, and then you go back uphill, basically to where you were, your functional level. However, for cancer patients, we have this kind of up and down, like spike and then down, spike and then down, where we have multiple insults. The patients have multiple insults. For example, if they were first diagnosed with cancer, they have a slope down of their functional outcomes because whatever the cancer is taking over their body. Then whatever happens, we do chemo, we rehab them after chemo, they get back, to their baseline. Then what happens? Possibly they need radiation, then they go back down again. They need surgery, they need a stem cell transplant. So all these things happen in their whole cancer rehab trajectory that you're a part of. And now, even better, we are starting to make waves for impacting their trajectory even before they get their surgery or their chemo or their radiation, because we're doing something called prehab, where we're actually helping them before they start their treatments and getting them to even better baseline before we start taking them down. So, of course, combining the love of medicine, combining the love of cancer patients, it really is rewarding. And, towards the end, yes, I think that I had a question, or I had somebody ask me, isn't it sad to do what you do? And I kind of looked at them and I said, yes, in a way, yes, it is sad. But, I think that it's just like any other part of rehab that we're doing. Like if we were doing brain injury, or if we were doing strokes, or general, amputee, isn't that sad too? But, at the end of the day, we all come to that single point at the end where we've made a difference in the patient's lives. They go home, they're thankful for the time and, for the help that we were able to give them.
Yeah, we're
So
all about increasing maximizing their function. And if you can help improve their quality of life, no matter how long it is, that's huge for the patient.
absolutely. Absolutely.
Function and quality of life, the foundations of PM&R, no matter what
Yes.
specialty, right? So,
Yeah.
all right. So you mentioned that we had talked about cancer rehab. Now there are a few more fellowships than when you had applied. There were 2, and now there's, I think, maybe 6 or 7. And MD Anderson is an ACGME fellowship program. So do you get to work with the fellows? Are you on staff there? And then can you tell us a little bit more about that program? And then in terms of residents who are interested in cancer rehab, how can they make themselves competitive for fellowship? What advice do you have for them?
Absolutely. So before, actually, I have to thank our program directors, Dr. Yadav and Dr. Anu Wan. These 2 people were instrumental in making these fellowship accredited. And so they've worked with other program directors across the country to make cancer rehab an accredited fellowship, which was an amazing feat. And now, of course, there's more and more people that are interested and more programs popping up. So our competition with other programs are starting to heat up. But that's bad for us, but that's excellent for the program applicants because they actually can choose, more programs, location, or things that they want to do, or things that they like. And so my advice for going in is just, demonstrating that you really have a love for cancer rehab. So how do you do that? Trying to do a rotation, or any kind of, if you can get away to a place to do a cancer rehab rotation, that's probably the best, so people can get to know you. And I'm just speaking in general, not necessarily for our program, but I think that will give you, number one, the exposure of the cancer patients, how sick they are, what is it, how is it different from your general inpatient rehab. And also you get to know the people that you're going to be in the future working with. So getting a sense of that, and also knowing, what is it like to actually work with the patients that have cancer. And I think that's the most important. I understand with coronavirus, everything going on, we've had a hard time like getting people in to do rotations, and some people might not be able to do a full rotation maybe for this year or for next year. But if that's not the case, then continue to do what you want to do, and maybe focus in on your cancer patients while you're taking care of the other patients, so that you get a little bit more experience. Also talking with the program director at your residency to let them know that this is something you want to do, you're thinking about it, and that way you can always find some connections, and in the field as well. And then when we do finally get to go to conferences again, go up to cancer rehab physicians, introduce yourself, tell them that you're interested. And I think that will help build some connections. And then, you can go from there. So all those things will help you get, better, number one, get to know cancer rehab better. And number two, make those connections so that you can get into a good fellowship program, which most of them are great fellowships now.
Awesome. So you're an assistant professor in the Department of Palliative Rehab and Integrative Medicine at MD Anderson. We're in the process of actually trying to get a palliative doctor scheduled to be on a show because we want to highlight that as well.
Oh, that'll be great.
Integrative medicine would be good too, Sheena.
Yes.
But yeah, they're all great. I think I love that they are all working together, and that you guys are under one department. How do you get to interact with these specialties? I take it probably every day. Can you tell us?
Yes, every day. And we're in it's kind of a special relationship that we have. Our program has all 3 departments. We have rehab, palliative, and integrative medicine all together. So not only do we share patients and we consult each other, but we also have like research projects ongoing with each other. So for example, like we might integrate yoga or meditation into rehab. And so we can just pull somebody from that department and kind of help us get those research projects. And also, when we're in the hospital or outpatient, we just consult them without any difficulty. So, and it's nice because they're just down the hall. Usually before coronavirus, you would see them, everybody, you can talk to them curbside if you had a question. But now it's a little bit more difficult to, get face to face, but we do, talk to each other on email or on Zoom, and then we're able to, say, hey, this patient has such and such. Do you think you can help me with this? So we
That's
do
awesome.
that as well. Yeah.
That's awesome. We're going to open up the questions to the audience, but I actually have 2 questions.
Oh, yes.
The first is, tell us a little about your inpatient, outpatient. Tell us, what does your typical week look like?
So we actually have a rotation where we have to, as you know, there's 8 physicians right now at MD Anderson. So we have 2 physicians that are in the inpatient unit, and it's staffed with 1 attending and then 1 nurse practitioner. And then we take care of, we have a 14-bed unit, so about 14 patients for those 2 attendings to take care of. And then the rest of us, the other 6 attendings, we're usually on consult service. So we run around and see consults all over the hospital. And the consult service, we're helping to deal with pain. We're helping to deal with people who are just so debilitated with their cancer treatments that they can't do much. So we're starting to help them regain their function. We work with a therapist on the inpatient unit. And then we try to bring them to our inpatient unit, or we try to, get them home. So that's the goal. And then we also do have outpatient. So each of us has a scheduled outpatient a day or half day, and then we do half day in our clinic so that we can have some continuity with the patients. So we do everything.
Rehab is like the kind, because you can see them on the acute side, inpatient rehab, and then afterwards. And I always remind my patients, I'm like, remember 6 months ago when we first met and you can
Absolutely.
I told you it was going to get better.
Absolutely. Yes.
Which is awesome.
Yes.
My second. Go ahead. Rock, paper, scissors.
All right. Okay. We'll alternate.
Yeah.
So we have one of our good friends, Dr. Sebastian Benz. He is watching, and he is in a similar situation as you as when you started. So when you started, you were applying to the fellowships, and you were offered this job and not having to do the fellowship. You were kind of, learning on the go. So will be in a similar situation in terms of he'll be working in the cancer rehab department. And what advice would you have for him in terms of, how do you just kind of get going, and how do you kind of learn on the job?
Yeah, so that is, I think it's a great opportunity. If you've already signed on for this, it means that you're dedicated, you're willing to learn, you're motivated. So I really would encourage him to read some of the chapters in the cancer rehab book. Stubblefield has a book out that really helped me. It has a lot of medical stuff so that you get the oncology background along with it. And then also I did a lot of reading on like Up to Date. I asked, my other co-attendings. It was weird because, when you first start, you're thinking like, oh, those are not, they're like my seniors, my attendings. And it's so weird to, say, oh, now they're my colleagues. So anyway, so they were absolutely like, please ask me if you have any questions. So I always would ask about, certain things like, what do I do in this situation? Is this patient too sick? And, I think you definitely do have some learning that you'll do on the floor when you are taking care of these patients. I think part of it is like, asking yourself, what is the risk benefit ratio for some of these patients too, because sometimes they're very sick and they only have a limited time. So I always ask, will rehab benefit? Of course, I'm biased. I would say yes, absolutely. And if they are very sick though, you kind of have to look at the acuity, how sick they are, and then look at how long, you think you can help them with inpatient rehab. For outpatient rehabs, of course, like definitely you should get involved in cancer rehab patient their care as early as possible. And so I think that, reading up as much as you can on topics And then also, don't be afraid to ask questions, colleagues. They're there to help you. And then I think that there is on Facebook, there's also a cancer physiatry. There's a cancer physiatry group as well, I think. So definitely you can ask questions there.
No, that's great advice. How has your practice changed since coronavirus? Because you're obviously
Oh my
working with
goodness, yes.
at-risk population, so I'm sure it's been
Oh
interesting
yes.
there, right?
It has been very interesting. Rehab is one of those things that you really need hands-on to touch, to know, what is their strength level. You're very limited with what you can do over video. But that being said, our population is very vulnerable because they have very, very immunosuppressed. They're very immunosuppressed with chemotherapy, radiation, cancer status. So you got to weigh the risk to benefit ratio. So how have we changed? So since March started, when it felt like it was just like one day, Zoom, everything shut down. Yes, and I was actually at a conference. I was at AAP, and I had just traveled and got in that day. And then all of a sudden, I got this email that was like, MD Anderson is no longer allowing people to travel. And I was like, what? What happened? Do we have to go back immediately? What's going on? And then basically after that, like everything went into like a lockdown mode. Patients could come, but they couldn't come unless they were in Texas. Visitors were completely, gone, and our office staff went to zero. So I don't know if that's the same where you guys are, but everybody that can work from home is encouraged to work from home. So we had to start working from home for a little bit. We could only try to go in as little as possible. When we went in, we had to, don on everything, but the supplies were hard to get. So there was also a supply shortage for your N95s, your PPEs. It was this very scary moment, but we made it through. We just all did video, and again, it was hard, but we did what we could. So we would ask the patient, could we see you on video? Is it possible? And they said yes, no. And then through the months, like the technology got better. At first, we were just like FaceTiming, doing whatever. And then now we're actually integrated Zoom into Epic. So through these months, they actually had to get better security, better video system. So of course, like some patients love it, some patients hate it. You're never going to have 100% of people that love it, or 100% of people that hate it. So somewhere in the middle, trying to do what's best for the patient. So what we do is, if it's really, really important that we see them. So for example, like to do a Botox injection, your procedures, you really need to come in, right? So I actually would just have them come in the same day that they might have other patient appointments with other providers, other cancer doctors, for example. So they just come in, we book all their appointments the same day, and then we just do, as minimum encounter as possible. And then prior to that, you want to see if there's anything you can do beforehand, medications, if any of those things work and they don't actually have to come in, then we could try that. Now we're starting to open up a little bit more. I think we're trying to get more patients in. It's been, 6, 7 months now where patients haven't been able to see us, where we haven't been able to, actually touch and do the manual testing, or to actually see what's going on hands-on. So now we're starting to say, it's not going away. So we're just going to have to now do something else to help our patients. And so we're starting to open up our templates a little bit more to see more patients come in. For the inpatients, however, we have to go in the hospital and we have to go see them. So we are doing that for the inpatients that are in the actual rehab unit. And then for consults, sometimes we're able to do a few follow-ups or you can even do a consult on the phone, but it's very limited, just trying to see what's going on. And then I usually tell the patients, I'm going to see you tomorrow. I'm going to come to the hospital tomorrow, and I'll see you, while you're there. And the patients, they go, oh yes, I remember you were on the phone with me. They recognize your voice, and there's no way they can see you now anyway, because they probably only see me from here to here, and then you got the mask, you got the face shield, your hair is up, you're in blue scrubs. So yeah, so that's how life has changed in just the past 7 months. It's been absolutely crazy, but what can you do?
It is interesting. It is.
Yeah.
We have a question.
Yeah. So Dr. Benz is asking about cancer fatigue and if there's a role for cardiopulmonary exercise testing in this population, CPET.
Absolutely. So cancer fatigue, actually, we work really closely with our colleagues in palliative medicine, because they also do a lot of cancer rehab fatigue. There's a lot of studies out there that was put out by Dr. Yenu, who is in our palliative department. So yes, there is lots of studies, lots of benefit to reversing the cancer-related fatigue with exercise. So that's that question about whether or not they need to do cardiopulmonary testing. However, I don't think that's been studied in the literature as much, but we do know that if they can do any form of exercise, any form of physical activity, it does help to reverse the cancer-related fatigue. So I think that that's a good question. Definitely, maybe more studies can be published. More research. So if Dr. Benz is interested in doing some more research in that area and more publications, because that's actually something that was brought up at the last AA PM&R meeting, our community day, that there's not a lot of studies in cancer rehab. So definitely we need more randomized control studies, more patients to enroll in studies, and to put more literature out there. Absolutely.
Awesome. Are you using any compassionate cultivation at all, CBD? I ask everyone this question.
Benecia's go-to.
I'm like so pro. I'm so pro CBD. I prescribe a lot of it.
So is that the legal form here? The legal form?
Yeah.
We have not. No, we have not. But I think that's a good question to ask my palliative colleagues, because maybe they use that more. I'm not sure, but for us, we don't. Probably the closest thing we use is like Marinol for appetite, THC derivative, but
you can only use it for terminal cancer, and spasticity is the main things that I am prescribing it for. But yeah, I actually had a cancer patient seek me out. He found me on the website for his terminal stage 4 cancer, so to prescribe it for. But yeah, but my patients that are using it are doing great for spasticity.
Yeah. I notice it's getting a little dark. I need to turn on the light here. So it's like the sun came out and sun decided to leave.
Time is changing, I think, in a couple weeks, November 1st. Well,
call back.
If you guys have any more questions, let us know, for sure. And then, shall we ask my question, huh?
Yeah, go for it.
So there's a little more light there.
Oh, we can see you. Hi.
Yeah. So sorry.
No,
sorry.
Fine.
Why didn't you tell me earlier?
No,
in the dark.
So, Dr. Ng, if you were not a rehab doctor, what would you be?
I love this question. And my question back was, how much money do I have?
I know, right? Good question.
Yes. I mean, I would be like a travel blogger. I would just go travel and blog on my travels and go, just explore the world if I wasn't a rehab doctor. But
Sheena could plan it for you.
Yeah, exactly. But yeah, let me call you after this. Okay. but if I was any kind of doctor, I was thinking about this, and I was thinking, well, if I was any kind of doctor and I couldn't do rehab, what would I do? I probably would still do internal medicine. It's my love of medicine, something that I would like to do. And, I was thinking, then you would still be able to work with cancer patients, but I would I would probably go be an internal medicine doctor.
A
But
lot of
yes,
people, I don't think, realize how much internal medicine that PM&R can actually do. And like, I think
yes,
you can be as hands-on or hands-off as you want to. Because I was like, where we
absolutely.
trained, obviously, you know, we were the internal medicine
Mhm.
doctors. Like, it was very rare we would
Yes.
have them come over. So
Yes, and some places do spoil you. I mean, MD Anderson spoils us. We have
I'm,
great people that we can consult, and they're
yeah,
there like in a drop of a hat. It is really spoiling.
yeah. Medicine
Yeah,
follows all of our rehab patients, which is nice.
uh,
Really.
that is nice, isn't it? You're like,
It is. I'm like,
they
oh,
got it.
yeah, I'm like, oh, can you hold me? But that being said,
Exactly.
I
Mhm.
did order a chest X-ray and diagnose pneumonia on an acute care
Oh,
consult today. Went for rehab.
oh wow.
I was like,
There
she
you
has pneumonia.
go.
I just ordered a chest X-ray for you.
There you go. You got it.
And we have another question that's trickled in. So,
Okay. Sure.
do you find that patients, oncologists, are more on the cautious side when it comes to rehab precautions or therapies, or are there more, or are they more amenable to pushing the envelope in terms
Okay,
of,
so
letting,
that is definitely, I think, knowledge dependent. So, meaning if they know about you, if they know what your specialty does, they're more amenable to letting you take over like their rehab stuff. So, for us, I think since I've been there, definitely more and more of the oncologists are now starting to say, oh, yes, we need to get cancer rehab on board. Um, get the physiatrist on board and start working with the patients pretty early, not just when it's time for discharge. But I think that the question is because if they don't know what you do and they don't know what you can do for the patients, of course, like they're definitely going to be protective, like, what are you doing? But when you establish a relationship with the oncologist, so anytime, go and introduce yourself. I'm Dr. So and so. I'm the cancer rehab doctor. Can I, I'd like to do this and this and this with the patient. They're more likely to say, oh, yeah, that makes sense. Absolutely, that makes sense. Um, with the precautions, they're always changing. So, for example, I would say that, like when I was in residency, we would probably say, oh my goodness, a platelet count of like 49. Oh, we can't do this. We can't have them lift weights. Oh my goodness, they might break. And at MD Anderson, we have patients that actually have platelets like less than 10, less than 5. We've seen some patients. Yes, we do have precautions for those patients. But do the oncologists say, you can't work with them? No, they do not. Actually, they call us in because they know that we will take the extra precautions and guide the therapist in knowing, you can do this, you can't do this, things to look out for. So I think the advice is really to get to know the oncologist, let them know what you do. And also, more research right now is coming out about, the thrombocytopenia, the cytopenias, pancytopenias that we all see in our patients. And then also like bony metastasis. Dr. Guo has put out a paper about spine precautions for, spine metastasis. And previous to that, we were spinal precautions. Previous to that, I think the therapists were, doing a lot of exercises with patients, and it was load bearing on the spine where they're having metastasis. So she found that the therapists really weren't, you know, thinking about what should be done, what shouldn't be done. So that's why she decided to do some research and then to put out a publication. So all of these things are now new and coming out, and definitely because we're able to do more with, we're seeing a lot more patients now that have cancer. They're living longer. So definitely, you'll see a lot more research going on with things to do and things you shouldn't do.
Yeah, that's awesome. I just got consulted on a patient this weekend that was recently finished her first round of chemo, and she got discharged from the hospital and went home and fell and couldn't get back up, so came back to our hospital. Yeah, but we're going to try to bring her to inpatient rehab. I'm like, you can do this. We're going to build you up before you got 3 weeks before your next round of cancer, next round of chemo. So yeah, it really does make a huge difference for these patients.
Absolutely. And the ones that do get some form of structured physical activity before their next treatment, whether it's chemo, surgery, or whatever that might be, they do have better outcomes and get out of the hospital faster, shorter length of stay, they get home easier, so you definitely want to try to reach them as fast as possible. Yeah.
Oh, good. I'm going to hit them when I have to do this peer-to-peer for inpatient rehab. I'm going to quote them. I'm like, actually, they do have
Dr.
according to MD Anderson.
Did you see that paper that was out?
Right, exactly. The studies say
exactly.
Let's see.
Right. One more question here. So for cancer patients still who are working, any issues or special considerations with getting employers to comply with any restrictions?
Yes. So I actually had a few patients. So some, it depends on their jobs, right? So some actually told me that their job would not do any kind of precautions or any kind of accommodations for them. So, just like with any return to work that you would do, you look at the same thing. So what does their job entail? Like, do they have to walk around? Is it a sedentary job, office job where they're on the computer? Do they have to lift weights? So same things that you would consider for any return to work. But the problem that we face is that for the cancer patients, like perhaps their treatments are ongoing. So, you have to take a look at, when they're going to get their next cancer treatment, their chemotherapy, their radiation, or surgery, and then try to plan with the patient about that. Sometimes I find that the patients are very eager to return back to work, and I kind of have to tell them to slow down, because it's going to take a very tough toll on them. Again, it's not like a single event, where you have an insult and then you get better and then you go back to work immediately after you get better, like you had a knee rehab, you had a total knee. It's not the same thing. Patients are going to get sicker. Usually, if they have a combination therapy like chemo, radiation, there's other things to consider, cognitive deficits with chemo brain, peripheral neuropathies with their chemotherapies. So all of these things. So again, the employers have to make some kind of accommodation, but usually what I find is that patients just they try, and then for whatever reason, it's either unsuccessful or, they do get an accommodation, but it might be for a short term. So it's not, I don't think that it's 100% like the best thing that I could ask for the patients, like my kind of accommodations that I would wanted for them. And sometimes they do have some difficulty returning back to work. But I hope that, our I don't know, our employer federation or whatever you call these people, make some laws. Our representatives could help some of our patients better, because I find that, it's really difficult to get accommodations for our patients, and it is very sad. And
no, I think they feel like they have to go back to work sometimes if they are if their insurance is through their job. They're like, I cannot lose my insurance. So it's a lot of pressure on them.
Because it's not cheap. It is not cheap when you're sick, and your insurance costs a lot of money, and you could be at risk for your insurance dropping you. Even Cobra, how much can you afford with Cobra? It's expensive. Absolutely. So definitely some of these patients are very lucky that they still have insurance, like through their employer. And then sometimes patients tell me like they can't go back to work, and they actually have to get on some kind of anything that yes. And we have at MD Anderson, there is a patient financial assistance program that can help patients, but it's kind of hard to get on too. So I do feel for the patients. Absolutely.
It is unfortunate. Well, Dr. Ng, we really appreciate you taking the time.
Thank you so
out
much.
And joining us. This was awesome.
Thank you so
I've learned
much.
a lot.
Yeah.
This was
I'm
very. Go ahead.
Oh, I was getting ready to say I'm so thankful that you guys asked me to be on this show. So it was great.
Yeah, thank you so much. So if anyone out there's watching later and they have any questions, what's kind of the best way for them to get a hold of you?
Anybody can email me. My email address is ang@mdanderson.org. And then they can also reach me on Twitter at Dr. Amy Ng, DRAMYNG.
Great. Yep. And I think we tagged you on our Twitter post,
Okay,
so it
great.
should be easy to find. So
Awesome.
thank you again.
Awesome. Thank you guys.
Yeah, you
That was
guys
great.
who are watching, you guys obviously know where to watch us, but share with your friends. We can be found on Instagram at virtual.physiatry.mentors.com. I get that wrong every single time. You guys know the name by now. And we're also, you can follow us both on Twitter. And this will be posted on our YouTube page and our IGTV. We will email you the YouTube link once Sheena gets it edited. We've had a lot of fun virtual physiatry mentor takeovers. If your programs are interested in takeover, hit us in the DMs and join us next week when we're going to be talking about solo private practice, which is really a rarity these days, with Dr. Satya Bhandari. So, yay. All right, guys.